All right. We're on 20, so I might just kick off. My name's Laura. I am one of the leads in the integration team at North Western Melbourne Primary Health Network. Thank you so much for joining us. We work with Mary Health and Commission, the chronic pain service, and two of those team members will be speaking tonight. So we're here to talk about new perspectives on pain management, including the roles of opioids and medical cannabis. Next slide, please. And before we go any further, North Western Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon-wurrung people, and the Wathaurong people. And we pay our respects to elders past, present, and emerging, as well as paying our respects to any Aboriginal or Torres Strait Islander peoples with us in the session tonight. Thank you. Just a bit of housekeeping regarding the Zoom meeting. So all attendees are muted, and please keep your microphone on mute. Any questions, please ask via the chat box, and we will refer to questions at the end of each talk. The session is being recorded. Please ensure that you join the session using the name you registered with so that we can mark your attendance, and certificates and CPD will not be issued if we cannot confirm your attendance. And just a quick information on how to change your name in a Zoom meeting. So click on participants, and then in the app, click on your name, or on a desktop, hover over your name and click the three dots. And on a Mac, hover over your name and click more. And then you can click on rename and enter your name you registered with and click done, change, or rename. Thank you. And just a little bit of information around health pathways. So many of you may know that Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and North Western Melbourne Primary Health Networks in partnership with healthcare professionals in the Melbourne region. Health Pathways provides a comprehensive collection of locally relevant clinical information guidelines and covers a wide range of conditions, procedures, and services. The information is structured in an easy-to-read format, making it convenient and easy for health professionals to utilise and access during their practice. So to navigate, like on the page you can use the table of contents on the side, or alternatively, you can use the search navigation bar at the top. Also, please be aware of the send feedback functionality, which is on the bottom corner of the page. Next slide, please, Nicole. So the pathways are written by GP clinical editors with support from local GPs, hospital-based specialists, and other subject matter experts. Pathways are clear and concise, evidence-based medical advice. Health Pathways reduces the variation in care and provides guidance on how to refer the most appropriate hospital, community health services, or allied health providers. Health Pathways also tells you what services are available for patients. Next slide, please. So in order to access Health Pathways, if you're not already registered, you can register via the QR code that's on the screen now, or you can go to melbourne.healthpathways.org.au to register. Next slide, please. And in terms of searching for a pathway, this is the landing page that you can see, and we've put in the search bar as an example, low back pain in adults to tie in with tonight's session. And this is just an example of relevant pathways that might come up. So I guess this is looking at lower back pain in adults. Thank you. And so this is the page then that if you were to click on that pathway, this is what you would see with all the options. And then if we look at the next slide, so that is the assessment section, and you can see it provides step-by-step processes and access to other relevant and helpful links. And then on the next slide is the management page that details different options and management strategies. And the final slide is the referrals page. And if you follow the links to Health Independence Pain Management Program, you could find more information about the Mary Chronic Pain Service. And so tonight, we're very pleased to have Associate Professor Dr. Malcolm Hogg, the Staff Specialist in Anaesthesia and Pain Management at the Royal Melbourne Hospital, Head of Pain Services, Melbourne Health and Clinical Associate Professor at the University of Melbourne, and Nicole Moore, the Senior Pain Physiotherapist and Project Lead at Mary Health, and Lecturer, the Doctor of Physiotherapy at the University of Melbourne, and Director of Mindful Being Melbourne. So I'll hand it over to Nicole now.
Thanks, Laura. I hope you guys can't hear bedtime going on as loud as I can. But I'd just like to spend a little bit of time with you guys before Malcolm talks to talk about back pain, and particularly to go over maybe 5 common beliefs and try to look through them look at them from a slightly different lens. Oh, apologies. I have just lost my screen in doing that. Bear with me. And before I want to start, I want to highlight that I am a pain physio and that we do exist. It's a titling process, a specialty process that we do through the Australian Physio Association, and we are out there. So if you're looking for referrals, highly recommend to look out for pain physios in your area. And just a little disclaimer that the presentation that I'm going to do now, it is from my perspective of having worked in a dedicated chronic pain setting for the last 11 years. So it's probably skewed to that demographic somewhat. Yeah. And what we'll go through, first we'll have a look at what we've been doing to manage low back pain and a little bit of how that's been working. And then we'll address 5 common societal beliefs and put them into question, maybe view them a bit differently, and then consider a little bit about what high value care might look like. So first, the prevalence in Australia is 1 in 6 people living with back pain. It's overrepresented in people with a low economic status. It's the second most common reason people come to see you guys, and one of the top 5 reasons people present to ED. And predominantly, it's self-limiting, and so 75% will have a favourable outcome, benign self-limiting back pain. But then there's 25% that develop ongoing symptoms and limitations, and it becomes quite disabling. So just a little snapshot of what we have been doing. If my mouse will turn. What have we been doing to manage it so far? And certainly medicalized management has increased. This is US data, but our trajectories are all very similar. We all know this. We over-image where we know it might not change the treatment process or the treatment outcomes or treatment pathways. And in my opinion or my experience, people that have imaging, they immediately stop being someone with back pain and they start being someone with a bad back. There was a 2019 systematic review of evidence that imaging is associated with higher medical costs, increased healthcare utilization, and more absence from work compared to non-image groups. Obviously, pharmacological management is on the rise that Malcolm will speak to, which has its place. But despite the majority of international clinical guidelines having prioritised non-pharmacological approaches as first-line care, they still continue to be first-line care. I think that's except for the Chinese Association for the Study of Pain. And there's been an overuse of inappropriate, often invasive procedures and surgeries, lumbar fusion, microdiscectomies. And in my experience in the chronic care setting, a lot of private physicians, private pain specialists doing radiofrequency ablations, and particularly on patients that probably haven't been trauma screened. And there's a lot of traumatization that goes on, and poor outcomes in this client group. We also have a lot of variation between LGAs in Australia. 2 examples are 12% variation in CT imaging and about 5% in lumbar surgery admissions. So guidelines aren't really being used or well used. And the messaging that I'm aware of out there is this messaging in terms of protecting. And I wonder if you can recognize any of these that you might talk to your clients about, and certainly they might be quite innocent at the time, but the underlying belief or emotion that comes with these is one of fear and one of the needing to protect. And fear fuels the protection fire, the pain fire. And in my experience at that chronic end of the spectrum, the things the clients are told that they shouldn't do, they end up being what they can't do. And there's this domino effect of themes of grief and loss from originally just avoiding or not doing certain movements and then activities, no longer bushwalking. And it affects their sense of identity, their social groups, and that spiral into disability. We've also been spending more money than we ever had on musculoskeletal disorders, more than any category of disease or condition or injury in Australia. So we've thrown a lot at the problem: invasive, costly, high risk procedures, medications, and still modern medicine hasn't solved the problem of backache. And in fact, it's getting worse. Um, it's still the leading cause of disability worldwide in the purple. And closer to home in Australia, it's been the number one leading cause of disease burden since 2003. And between that and last year, it's gone up by 7.7%. So all of this spawned the Lancet Back Pain series, which was a series of 3 papers that came out to raise awareness of this rising global burden of back pain. But importantly, it proposed that back pain's societal burden is driven by an epidemic of low value care. This includes inappropriate use of imaging, the overuse of pain medicines and spinal surgery, and an over reliance on passive treatments without a predominant focus, with a predominant focus on just palliating symptoms. And from that series, we have now developed Australian back pain clinical care standards, and that was based on local international guidelines and expert consensus. But I just want to ask the question, how did we get to this? And I want to specifically ask, well, do we know what we're treating? Especially when it comes to that 90%, the predominant group of non-specific low back pain clients. And we tend to focus on the triggers of back pain and the peripheral structures and the mechanical aspects, which are often not the cause, because the cause is complex. It's a mix of interrelated factors that the socio-ecological model tries to illuminate. And we know in the individual layer here has a really big significance in terms of past experiences. It's been shown that individuals that have 4 or more adverse childhood experiences, and that can be traumas with a little t where needs weren't met, or a parent with a mental health condition, or a divorce, they're 2.7, almost 3%, 3 times more likely to develop chronic pain than people without any ACEs. And we're pretty good, I think, us clinicians, of getting a developmental history and understanding how trauma might be impacting this person's pain. But something I think we're not good at and that we could really improve is translating that to the client, the patient, and helping them see the links to what's happened or happening in their life and what's happening in their body. And there is really good assessment processes to do that I can point you to. If you're interested, do get in touch. But what we're focusing on today is not this individual layer, but the outer layer, the environment and society, and how that can impact with back pain. Some might remember the Lithuania whiplash study. This is in a similar vein. In 1989, when the wall came down in East Germany, in East Berlin, back pain had a lot less prevalence. And over the 15 years since reunification, back pain kind of evened out between the West and the East. And it suggests the harmful influence of back-related beliefs and attitudes that might have been transmitted from the West to the East. And the authors go as far as to say, well, back pain is a communicable disease. So, with that in mind, based on this editorial that came out in between the Lancet series and the quality care standards, I'd like to look at what are some of our beliefs that are circulating in our society now. And I'll just take 5 of these. And we're really here talking about that, again, that non-specific low back pain group. But it's also based on what I hear people say in clinic. And maybe you guys hear people say this as well. I keep re-injuring myself. I have terrible posture. I have been bending properly. Oh, I've got a labourer's back. I'm done for. That's it. There's no use for me anymore. Or I tried exercise and it didn't work. So let's have a look at the first one. So is back pain caused by injury or damage? And I'm sure by now you've all heard of the infamous Brinjikji systematic review of over 3,000 patients, asymptomatic patients that came out with a whole list of different pathologies in the spine. And there was a study that came out from the same group not long after that that actually said, well, there also is a bit more correlation with some particular pathologies with back pain. But generally, we know that pathology isn't a really good indicator of whether someone will have pain. We can't look at an MRI scan and find pain. We also know that symptom severity doesn't directly correlate with pathology, and this is particularly true in osteoarthritis. And the degree of pathology doesn't predict future pain or disability. And 30% of individuals who have surgery to fix what's seen in a scan, they don't do well. We also know that when we ask what triggered your back pain, 1/3 of people can't recall a mechanical trigger. And acute low back pain is linked with periods of high emotional distress, linked with maybe somewhat minor, insignificant mechanical stress. So, this is again bringing into question the role of the immune system, of being run down, or illness or infection, of poor sleep, of stress, interpersonal and emotional factors. And my invitation is that we move away from asking, well, what did you do? And ask our individuals, our clients, well, how have you been feeling? How have you been sleeping? What emotional load have you been holding? What kind of thoughts have been cropping up at the time of your back pain worsening? And the strongest predictors of a pain flare are actually inactivity, stress, and depression. And I just want to give an example here of a client of mine I saw just last week, and I saw him for this session a few weeks ago. He came in, it was a perfect example. I got him right in the middle of a pain flare, back pain, and he'd had the pain for 4 days, and he just could not figure out what he'd done wrong or what he'd overdone in his usual activities. And he was trying to find things that were visible here on the outside of the iceberg. And he came up with nothing. At a stretch, he had one poor night's sleep, and that definitely plays a role. He'd reduced his exercise, which was really valid. But as we got through the session and I could ask him deeper into, well, how have you been feeling? Let's go back to the exact day of the week that your pain flared. When did it happen in the day? What time of day was it? What were you doing? What was happening emotionally? What was going on interpersonally? And he brought up something I thought was really significant. He had a telephone call with his sister in the UK, and it sounded like a really emotionally challenging conversation. But he did just move beyond that conversation without any real interest. It wasn't really a trigger. And then after some time, he just came up with, well, actually, I did go out with my sister, and she told me about my other sister that she bought a house in Canberra. And I was sort of thinking, okay. And this obviously had really triggered something in him. I could see his anxiety rising as he was speaking about the story, so much so that he kind of went into smooth muscle anxiety. I had to regulate him back into skeletal muscle anxiety. When he was back on board, we could probe a bit further into the emotional aspects of that. And straight away, he starts rubbing his back. He says, oh, my fatigue's come on. I feel so fatigued. And that was just such a enlightening moment for him that he couldn't move back from. He'd had the real experience of the link of what was going on in his emotional life with his pain. And we'll talk about him a little bit later, because we know that emotional pain is physical pain. They're very hard to separate the two. This is one study of emotional rejection, which demonstrates the neural overlap, even in the typically more sensory discriminative brain regions, in this case, the secondary somatosensory cortex and the dorsal posterior insula. And we know that over time with pain, the neural correlates start more to be in the sensory discriminative motivational areas, and here's the emotional areas. And in those that develop more persistent pain, the emotional areas tend to take over. So it could be said, and they say it in this article, that chronic low back pain is an emotional problem. Let's move to the next one. I have terrible posture. Well, while posture might be more relevant with probably a diagnosis of like HEDS, hypermobility syndrome, psychogenic headache, there's no evidence in the literature that back pain is caused by bone or joint or discs in the back being out of place, or that the pelvis is out of alignment. And in the small number of people with some changes in their spinal alignment, it doesn't appear to be strongly related to back pain. And it's worth saying that a lot of people feel better after undergoing manipulative treatments, but the improvement's often short term, and it's probably due to reductions in muscle tension, autonomic nervous system regulation, reduced fear, rather than the realigning of body structures. So generally, people in pain are more tense, stiff, and hold more upright postures, are more guarded and rigid and protective. People with back pain have moved slower, have reduced range of movement, and they don't relax. We know that spine posture during sitting, standing, and lifting doesn't predict low back pain or its persistence. And the key might be getting a variety of movement nutrients. That's my kind of terminology. And this comes from the studies we know of the somatosensory cortex, the homunculus, and the part that represents the low back, how we know that blurs and smudges and displaces in clients with low back pain. And that's probably because we're not giving the right kind of movement input into the brain, because the movement's so severely reduced. We're not bending, we're not flexing, we're holding ourselves really rigid. And the less data that's going into the brain, and the more uncertainty, then the more threat, and threat equals pain. Number 3, I have been bending properly. So is it dangerous to bend with a flexed spine? Because certainly there's a lot of movement to have a straight back and have some lordosis with bending. And there's strong beliefs that activities like lifting, bending, twisting are dangerous and should be avoided. But the research hasn't supported a consistent association between any of these factors and back pain. And of course, a person can strain their back if they lift something awkwardly or lift something that's heavier than they normally would lift or are conditioned to lift. Same as if you have back pain, of course, these activities might be more sore than normal, but it doesn't mean that the activity is dangerous or that it should be avoided or that the vertebrae and discs are fragile or susceptible to injury when loaded. And lifting is normal. It should be practiced to prevent avoidance of that movement and to help strengthen the back, similar to returning to sport after spraining an ankle. In this systematic review, they compared studies lifting anything from a pen to 12 kilograms, and they concluded that the risk relationship between lumbar flexion and low back pain is not demonstrated by research in this area. Lifting advice and training in healthcare and workplace settings also hasn't been accompanied by reduced occupational low back pain. And in this systematic review, they suggest no evidence that advice on lifting and handling with or without lifting equipment prevents back pain or consequent disability. Such lifting advice, interestingly, initially when there was the big wave, I'm not really sure what era that was when it all started, but it was based on cadaveric studies. And those studies found that the lumbar spine was susceptible to failure when repeatedly flexed, and weaker when flexion and compression were combined. But then I guess we have to ask, well, how reasonable are cadaveric studies to live in vivo humans? And so this study of live real people are pain-free biomechanical studies. They support that, and an increase in disc pressure, compression, no increase in disc pressure, compression, or shear strain when lifting with a flexed, which is this guy here, versus a straight spine. It also showed that lifting with a lordotic posture resulted in reduced neuromuscular efficiency, and that lifting with a flex spine significantly improved overall strength and neuromuscular efficiency when lifting. And I thought it would be kind of fun just to see that in action. This is Eddie Hall, and he's obviously very well, his body's very well used to lifting 500 kilogram weights. He's conditioned for it, but there's not much care for trying to stick his bum out or have a straight spine there. No, we don't know what's happening on a vertebral level, but he's certainly not trying to have an extended spine. And we know that during heavy squatting and deadlifting, the lumbar spine will typically flex to about 50 to 80% of maximum flexion. And actually, when people are coached to maintain a lordotic, an extended posture of the lumbar spine when lifting, flexion relative to standing posture still occurs. So, number 4, I've got a laborer's back. Well, there is evidence to say that being in a routine and a manual occupation it has increased with increased workloads is associated with back pain. But it's difficult to tease that out from other confounders often associated with lower socioeconomic status. In this lab study investigating the impact of the interaction of psychosocial factors and individual factors on spinal loads, they concluded that psychosocial stress and mental processing, which included stress such as pressured to finish tasks at a certain time, during lifting resulted in an increase in spinal compression associated with increases in trunk muscle co-contraction and less controlled movements. And we know that transitioning from acute back pain to chronic back pain, the most important predictors to chronicity there and sick leave are not anatomical, but psychosocial. So maybe it's not about how physically demanding someone's job is or how their scan looks, but on how they're doing emotionally and socially at work and at home. So we know that this is also shown in the twin spine study. They investigated possible determinants of disc degeneration, and those determinants were occupational exposure, driving and whole body vibration exposure, smoking, anthropomorphic factors, and heritability or genes. So what do you think would be the biggest, most significant influence on disc degeneration of those ones? Does anyone want to write in the chat which one you think it would be? Anyone out there want to have a guess? Smoking? Yep. Well, yep. Oh, we've got some numbers going here. Yeah, well, the answer is number 5, genetic. And interestingly, despite extraordinary differences between the twin siblings in occupational and leisure time physical loading conditions throughout adulthood, there was little effect on disc degeneration. There was a small effect on smoking on twins that had markedly discordant smoking exposure, more of an effect than that of loading. There was no evidence for whole body vibrations, and the effect on anthropomorphic factors like body weight and muscle strength on disc degeneration, although modest, appeared to be greater than those of occupational loading. So perhaps socioeconomic and lifestyle factors may play a larger role than mechanical factors in low back pain. We also know that the discs, the intervertebral discs in this study, when gradually loaded, they get stronger and more robust. They actually hypertrophy in response to loading, similar to muscle with resistance training, suggesting that the discs are adaptive to exercise and physical demands. And the study even indicates that routine loading may actually have benefits for the disc. And then we also know that using degenerative language, particularly in the OA literature, like wear and tear, it's associated with passive behaviors and poorer perceived prognosis. And lastly, I tried exercise and it didn't work. Well, do we have to be pain-free to exercise? Well, we know that regular exercise can reduce central facilitation of pain, so help with that inhibition, central inhibition. We also know that when we restrict people from their usual activity and exercise, they become more anxious, tired, depressed, and have increased pain. And this systematic review suggested that pain during exercise needn't be a barrier to successful outcomes. So perhaps we need to stop this messaging of, well, let pain be your guide, because that promotes a lot of avoidance, and increases in pain are normal with activity as long as that exercise is graded and appropriate for the person's ability at the time. But initially, the pain will increase maybe over weeks, but then it will go down. And maybe the key there is manageable pain. Can I still perform my daily activities? Is my mood not too severely affected? And that would be a better guide. We also know that having pain with movement can be a really nice corrective experience if we're using a bioplasticity approach. And I probably won't have time to go into that. But what kind of exercise? Well, the truth is that effect sizes for being active or exercising for low back pain are actually quite modest and not really much better than any other treatment options on back pain and disability. But of course, there are really great benefits of exercise, and it is low cost, low risk. It probably offers support while the natural history of back pain kind of plays out. Maybe it diverts rushing to riskier, more expensive options, and it promotes an active approach to recovery. So, good for self confidence, reducing deconditioning. And studies have shown that there's no one exercise that's better than another, and actually, that whole body exercise is recommended. And so I don't know if you guys are referring out for core stability for your back pain patients, but for the most part, it's actually not helpful, particularly the messaging that comes with it, that your spine is unstable, that you need to protect it, because people run with that. They don't just do it while they're in the Pilates room and exercising. They hold their core in all day, every day. And we know that people are more stiff and they move less. And it creates this vicious pain, fear, tension cycle. So while on its own, it's probably innocuous, the messaging that comes with it is quite harmful. And Pilates was removed from Medicare funding some years ago because the efficacy and the literature started to turn on it, as did the core stability research that initially came out in the 90s and has now been turned over. But exercise for mental health is super valid, and the dosage is a lot smaller, a lot lower than for physical gains. We don't have guidelines, they probably need to be created, but the evidence suggests some is better than none, and the best is interval training. So to end, I just want two slides, I think, on high value care for back pain from a physio perspective. And here's a bit of a flow chart of how we can stratify back pain, acute low back pain. And of course, we're really good at looking for the red flags and the specific pathologies and disease. But what we don't do very well, I believe, is concordantly screening for the yellow flags, assessing the socio-psychological factors up front. And what this does is it legitimizes the socio-psycho aspects rather than waiting for all the biomedical factors and tests to kind of come out inconclusive. And then, oh, well, we better look at stress then. Putting it up front is a really important message to give to our clients. And we tend to have this other box here that sits between these two, and I kind of call it a purgatory, where people are neither neither. They're not in a specific pathology category, but they're also not classified as non-specific because we keep chasing more scans, more investigations. And I guess we've just got to ask, well, how long do we keep searching for the structural source of pain when the evidence or concept of pain is an emergent property of the person rather than an input from the tissues? But if someone is lucky enough to get a nice clear diagnosis of non-specific low back pain, we also often just stop there and that's it. But we can go one step further, and you might be aware of the latest ICD. I think it was a couple of years ago now. It had chronic primary pain for the first time as a legitimate classification, so not just pain secondary to some other disease or injury. But we're not probably that good at translating that diagnosis of nociplastic pain, chronic primary pain, into practice. And that can be really powerful because when we rule out the red flags, we can also rule in nociplastic pain. And there's a really nice system of doing that. I'd be really curious to hear from you guys if you feel confident in diagnosing nociplastic pain and what you do. Um, it's actually, I think the term psychophysiologic disorder, George Engel, who was the psychiatrist who coined the biopsychosocial model in the 70s, he was one of the first to use that word, psychophysiologic disorder, and that's what they use in the States a lot. Um, but what that is doing is basically what we talked about earlier, helping a client understand what's happening in my life and how does it impact what's happening in my body. And when that has been made, the treatment pathway is really different because then we're looking for pain eradication. Then we're looking at using a mind, body, and a bioplastic approach to reversing their pain. And just a little note on high value care in terms of physio. What the clinical care standard mentioned earlier highlighted was that unfortunately, physios don't always follow evidence based guidelines when managing low back pain. And if physios were to implement the clinical care standard, they really would have to reduce the use of some well known interventions like ultrasound, which the effectiveness of is dubious when studies show you don't even need to turn it on for it to work. There's also good evidence to suggest that manual treatments aren't changing biological structure or altering biomechanics in a significant way. And physios would really need to start taking up new approaches that are unfamiliar to them, a psychologically informed practice, cognitive functional therapy, pain reprocessing therapy, pain neuroscience education. But as a tip, when you're referring out to physios, do look for pain physiotherapists, or at least for physios that are working on active management approaches, graded exercise, addressing fears and beliefs through an informed, holistic bioplasticity perspective, if possible. And referring to us, there's a QR code for more information on our website. And don't hesitate to email me about any referrals or give me a call. And thank you for your time. I'd love to hear if Malcolm has any thoughts, or if there's any comments or thoughts in the chat.
Thank you, Nicole. I think a lot of those principles are applicable to those that do have red flags and that do have some
Yeah.
pathology. So we're talking
Mm.
about the 90% that have non-specific low back pain without clear pathology, or we don't understand the mechanism of introduction or the initiation of that pain. But there's another cohort who do have a component of pathology, but how much of that is upregulated through the nociplastic processes. And so those principles you've explained are relevant to that cohort as well.
Yep, that is true. And going through a nociplastic pain assessment doesn't have to be just because they don't fit into a structural pathway. There can definitely be an overlap.
You did comment about private sector. I mean, this is distorted by the funding stream. So there is a funding model for radiofrequency ablation of facet joints, yet we know the facet joints are one component of the movement of the spine. And it's great conjecture about the efficacy of radiofrequency ablation in patients with facet joints, potential with low back pain and cervical pain for that matter as well. So there may be a subgroup who have predominantly pain initiated from their facet joints, but it's a small subgroup. So any benefit from radiofrequency ablation is often short-lived or mild at best. The best randomized controlled trials did not demonstrate compared to placebo its efficacy.
Just a quick one. Does anyone out there feel confident with a nociplastic pain assessment, or have tried it or do it, or what are your general comments or thoughts on that?
In my experience, I think GPs are very well placed to do this because they have the potential to know their patients very well over a long period of time, so they can build up. Specialists, on the other hand, often have a short one-off appointment and they skip over many of these factors.
Certainly, I think it brings a lot of value to your practice as a clinician, because it does prevent the overwhelm with the many overlapping centrally mediated disorders that people come in with, from dizziness to migraine to headache to irritable bowel, and it can be really rewarding to learn more about how to accurately assess and diagnose for that. So if anyone does want to know more, I'm happy to send some links if you send me an email. Oh, Malcolm, I think you've got your mute on.
Apologies. So yes, I do some consulting work. I work at Royal Melbourne. The consulting work with the Department of Health has been around drugs of dependence, and I was on the Safe Script Development Committee. I also do some education through pharma, but if there's any honorarium, it goes back to my employer. This talk is really about, in part, my journey from an anaesthetist and going through to caring for people in the post-operative phase, in the post-op pain rounds, and now the predominant work I do is in the chronic pain clinic, both at Royal Park, at Mary, but also do some telehealth into rural areas. So as an anaesthetist, we know that the surgeons come along and cause tissue damage, and we need to blunt that response in order for patients to tolerate surgery. So we do that with a local anaesthetic blocking the nerves. We may do it with a spinal anaesthetic blocking the spinal cord, or in the vast majority, we use a general anaesthesia. And under general anaesthesia, we know that there can be significant hemodynamic responses, and this is through the pathway of the nociceptors through second-order neurons in the dorsal horn of the spinal cord and up with branches into the hemodynamic centers in the midbrain before they terminate in the thalamus. Then what's important is that from the thalamus, there's three cortical networks and thalamic corticonetworks that cover the sensory component of pain in the parietal lobe, the emotional part of pain activating the mesolimbic system, anterior cingulate cortex and basal ganglia, and then an evaluative component of pain where there's a circuit within the frontal lobe that gets activated, whereby a patient has a neurological basis for why their pain is multidimensional, having sensory, emotional, and evaluative components. And if I fail in my duty as an anaesthetist and don't give enough hypnosis, then what's clear in patients who suffer awareness of surgery is that they have very strong emotional experiences and often linked to PTSD. And this reflects the activation of the frontal lobe and becomes important as the meaning of that pain event becomes more prominent in recovery. So going further into the post-operative period, we know that all patients with trauma-related or tissue damage pain, there's a degree of sensitization that occurs. And that can occur in the periphery, so how much bleeding occurs, how much infection, for example, in a wound, radiotherapy, where the peripheral nerves have been upregulated and respond to a greater degree. A second type of sensitization occurs at the spinal cord. So if we have poorly controlled acute pain, we have increased activation of the spinal cord level and more permanency and upregulation of the pain experience. And then the third type of sensitization is occurring in the brain region, now referred to as supraspinal sensitization. So this might be where there's high levels of anxiety or high levels of associated meaning to the pain event that there's upregulation. It is also a sort of a neurological basis for why there's that strong connection between adverse childhood experiences or the developmental phase of a person's neuronal network within a threatening environment, and then a new onset of pain as an adult from a new, different source can lead to heightened brain responses. We also note this in experimental settings. If you change the context that a stimulus is applied, the brain pattern changes, as does the resultant pain score and response of the person to the stimulus. Now, once we have tissue activation, we should then be modifying it, and there's a phenomenon called descending inhibitory control, now termed conditioned pain modulation, whereby if you have pain coming, say, for in this example, with an immersion in an ice bath, that will become cold, very painfully cold, and if you maintain it there, you will activate descending inhibition. And a lot of this is opioid based, but there's other neuroreceptors involved. And when we measure the pain response, on the other hand, we can demonstrate a reduction for the same stimulus in their pain experience with this conditioned pain modulation. 95% of the population can demonstrate inhibition, and some groups are very strong. Specifically, triathletes have been identified and military personnel. So you can train this descending inhibition. Another way that we look at how pain is sensitized through this system clinically is that there can be an increased upregulation called temporary summation. The longer you give the person a painful stimulus, the nervous system will upregulate, and how quickly and how the severity of upregulation is referred to as temporal summation. We know that if we do these tests on people before surgery, it can predict how severe their postoperative pain is, and it also predicts the risk of transitioning into chronic pain. So when we epidemiologically look at people transitioning from acute pain to developing chronic pain, the single biggest predictor remains the severity of acute pain. So if there's lots of nociceptive input into the spinal cord and upregulation into the brain, then that increases the risk. So paradoxically, if we are aggressive in our early pain management, including higher use of opioids, we can actually have less chronic pain. The other aspects epidemiologically, however, are psychosocial. So yes, there's a genetic influence we've just heard about with regards to back pain. That's also applied to the event and chronic pain. However, this likely links in through the experience of anxiety and catastrophizing and the risk of depression. Adverse childhood experiences we've mentioned, but also past pain. So if there's been repeated past pain and repeated high pain cognitions, then there's a higher incidence of transitioning from acute to chronic pain. My last comment there is about compensation or solicitous systems. So as people transition from acute to chronic pain and then start demonstrating that they're not recovering, the importance of their workers' compensation or TSC claim actually increases in predicting chronicity at 3 years. So these learnings inform the fear avoidance model. So the fear avoidance model came about in part through that biopsychosocial model, demonstrating that there's significant social and psychological factors influencing a person's recovery or transition into chronic pain. It's a little bit more complex than just, I have anxiety and catastrophizing, I stop working, I stop using my body, I increase my pain event, I get depression, I'm socially isolated. That's a very negative feedback loop. It's a little bit more complex, whereby we have a balance between risk factors, distress, trauma, fear, and catastrophizing, and protective factors, appropriate social support, active coping, some degree of acceptance of their emotional state and their physical experience of pain, and strong self-efficacy or internal locus of control, such that the patient takes control on their recovery. And it's this balance that seems to be influencing the transition from acute to chronic pain, and what we're trying to look at in that subacute phase to improve the recovery profile. If patients don't recover, they end up with the classical chronic pain phenotype, where they present with hyperalgesia, They have poor cognitions, and there's significant numbers of studies now showing poor neurological cognitions, memory in those that are receiving ongoing or active ongoing pain complaints. There's sleep disturbance, and there's significant physical deconditioning. Psychologically, there's a strong association with depression, which I'll talk about shortly, anxiety, and health-related worries. And finally, I don't see too many wealthy, well-adjusted patients with chronic pain. They have consequences of their pain on their social setup, their employment, and carer stress. If we go back a second and say, how do we classify pain? The nociceptive pain is what we've just talked about, looking at sort of surgical trauma. Neuropathic pain occurs if there's injury, direct injury to the nervous system, the somatosensory nervous system. The biggest predictor is, strongest association is thalamic hemorrhage. So all those nociceptive fibers are going through the thalamus. If you injure the thalamus with a hemorrhage, then very high rates of very difficult to control central neuropathic pain. Something like shingles, however, is a mixed system. So this initially will be inflammation of the axons, so there'll be a radicular component. Then there'll be tissue-related pain, so there'll be a nociceptive component with inflammation. And thirdly, there'll be some changes in the spinal cord and potentially thalamus, so they'll have a central neuropathic component. So someone who has poorly managed or severe shingles will have an initial radicular peripheral neuropathic mechanism, a period of time with a nociceptive mechanism, and then a longer period recovery phase where they'll have a central neuropathic component. What about the nociplastic word that Nicole's been using? I've tended to move away to now just talk about sensitization in general and talk to patients that for all patients with pain, there is a degree of sensitization. It's just how predominant is this in their presentation at the current time. So for fibromyalgia and migraines, it may be a strong component of their experience versus in someone who's recovering from a hip replacement, it might just be a smaller component. However, if that hip replacement's complicated by infection, then there's a higher component coming from the nociplastic or upregulation sensitization component. What about aging? Contrary to popular belief, the nervous system in the older person does appear to have an increased threshold in order to activate the pain system. So whilst we know epidemiologically they have high pain experience and high pain reports, their actual ability to trigger the pain experience initially is heightened. So they are late in presentation, particularly with visceral pain. However, once it's up and going, their ability to downregulate with this inhibitory control and then recover from an acute pain event is delayed as well. So it's slower. So I think of the older persons often presenting late, or if they are presenting, then I need to take this seriously, and then they have a longer recovery course, and I should be willing to give them medications for longer. The other thing we know that they accumulate pain experiences. So they have fractures, they have cancers, they have treatment-related side effects. So the epidemiological studies are the frequency and the prevalence of chronic pain in the older person is higher. Going back to that neurological matrix in the brain, we do know that there's a shared circuitry with the affective areas and high linkages, bidirectional relationship to depression. So 40 to 50% of those who develop a chronic pain state develop coexisting mood disorder, but often it takes 6 or 12 weeks, sometimes longer, for that to be clinically identified. Those with depression or anxiety before the onset of their pain have, again, higher pain experience, prolonged recovery, and have higher rates of persistence. So this is felt to be due to shared neuronal pathways of this network and matrix of circuitry within the mesolimbic system. We also know that those that suffer coexisting pain and psychiatric illness, particularly depression, have higher rates of suicide. And this, in some studies, is up to 4 to 5 times higher, and it may be for those with poorly controlled pain like neuropathic pain, or those with a feeling of hopelessness, mental defeat, high levels of catastrophizing. There's also a strong link with opioids. So if you look at the American data, of those coming back from the Iraq War, there's a strong association with PTSD, depression, and higher rates of opioid prescribing if they have those conditions, whether that is there to treat their anxiety and depression with higher rates of opioids, but they then become in a high risk group for suicide. So this shared risk factor becomes important also when we talk about opioids and addiction or dependence. And there's a lot of focus about the use of acute pain, opioids in acute pain, and that if we continue to prescribe opioids, we're exposing people to a risk of addiction. But if you look at the statistics and the longer term data, and this is both American and Australian data, that the rates of dependency is low if there are no risk factors. So less than 1%, and in one of the largest studies, it's as low as 0.2% per year. Now, if you have a risk factor for dependency, that such as alcohol, family history of dependency, past psychiatric condition, then that increases to between 3 and 6%. If you also develop chronic pain, then it likely goes up to as high as 20%. So if you have a patient in the acute setting that you're using opioids with, and they have similar risk factors for chronic pain, then they're at risk of developing chronic pain with opioid dependency. Possibly our association studies and concerns about repeat prescriptions and how they're linked to later on having dependency is this process, meaning potentially asking for repeat prescriptions is a way that the patient is identifying themselves as being at risk for both developing chronic pain, developing mental health disorder, and potential for addiction, rather than us thinking, we keep prescribing opioids, we are putting them at higher risk of dependency and we should stop providing. Another factor which we shouldn't overlook is that the system and the way the providers provide the opioids is important in risk. So when we look at the American data, it's in the order of 2.5 to 3 times the risk for oxycodone dependency per capita than it is in Australia. And one of these is about the system. So they can get 100 endone on discharge from hospital. They have a consumer-driven healthcare system. They have GPs working in isolation. And they have low socioeconomic and low social support networks. So the population and the health system contributes to the potential risk for a person developing opioid dependency. So these issues inform my pain assessment or our pain assessment. We want to know about who the person is, their medical conditions, looking for their yellow flags, who are flags or psychosocial factors associated with increased risk of disability and distress. Initially coming out of the workers' compensation data from New Zealand, identifying those that didn't get back to work. They also identified red flags, clinical indicators of possible serious medical conditions. Is this a nociceptive issue? Then what's the impact? Biologically, psychologically, and socially, and ultimately the goal is to restore, maximize function. And in the acute setting, it's about giving opioids so they can deep breathe and cough and mobilize. In the chronic setting, it's about limiting opioids but restoring psychological and physical health by doing allied health-based pain management programs. And then I like to know about where people are in the journey. For many, they are in the process from acute to chronic pain, or they may be very well established in chronic pain. And there can be blue and black flags that solicit us in maintaining the disability and the distress. And this is just a couple of studies out of Australia looking at this trajectory from trauma and going, what happens as the people recover? There is reducing rates of pain and disability down to about 25 to 30% at 6 to 12 months. But an interesting thing occurs from there is that the rates go up from about 12 months to 3 years. And if a patient can be identified that has one of these trajectories, and specifically one of the trajectories is exacerbation, and this is strongly linked into a lot of the psychosocial factors associated with their injury. So these learnings direct us to how we should manage pain. So the first and the primary component, both pre-operatively in the early post-operative phase, but also in chronic phase, is about patient education. We believe this works neurologically as a decreasing the brain perception of pain. Pharmacologically, opioids, clonidine and local anaesthetics are there for nociceptive pain, non-steroidals, biologics, antioxidants, where there's significant inflammation, whereas ketamine blocks, local anaesthetics, clonidine and the antineuropathics are there if there's significant nerve injury, pain or sensitisation. We don't quite know where to put cannabinoids in this classification. They are not relevant and effective in acute pain, and they may actually be a poor aspect in acute pain care. However, we do have some MRI studies suggesting that it can decrease the affective component and the meaning of pain at a brain level. So I view them as something that decreases the perception. There's another argument about having a low-grade anti-inflammatory effects, and so possibly they may assist with inflammation, but that inflammation is predominantly, or appears to be most beneficial, when it's in the cerebral nervous system. So it's anti-neural inflammation. And then there's a large number of non-pharmacological approaches which are treating both the nociceptive and possible and the sensitization components. If you go back to the injuries in the trauma group, we used to think about avoiding the lawyers, but if there's a clear perceived injustice, if there's a clear issue, the earlier you get an apology and settlement of the claim, the earlier and the easier the patients can recover. So where do opioids fit? So they sit as anti-nociceptive. We use them for surgery under anaesthesia. It blunts the hemodynamic response to surgery, so it controls their blood pressure and their heart rate response. Very good in acute pain, and possibly the higher you use the doses and the more aggressive you are, you actually get better recovery. The problem is they fail, and they fail over time for several reasons, but one of them is the neuroadaptation, which includes underlying sensitization of the pain system. So yes, you get tolerance, so you get less response, flattening of the dose response curve, but you also change the axis of the curve so that you've got underneath the opioid, you've got a hyperactive, hypersensitive pain system. There are a number of psychosocial reasons why they fail, including anxiety specifically, but also the lower rates of dependence and addiction and possible diversion. Opioids should always be prescribed with anti-hyperalgesic mechanism, meaning even simple paracetamol, but non-steroidals, clonidine, or a nerve-related agent in order to prevent the development of opioid-induced hyperalgesia. And this is why we're now transitioning to the dual mode of actions, because there is some built-in anti-hyperalgesic benefit. These are some references for perceived injustice. So this is where a patient will suffer a loss and there'll be an external attribution of blame. And these are strong predictors of people's recovery. At that 3 to 12 month mark, this becomes increasingly relevant. So we're asking people about, how did the accident happen? Who caused the accident? How do you feel about it? And if they're angry, it wasn't their fault, and they've lost a limb or a hand or a function, then they have high perceived injustice. And that's an influencing factor in how they both experience their pain, but also how then they engage with rehabilitation and their ability to return to employment. So I want to rush through a degree of issues about opioids. This is Explain Pain. So this is Lorimer Moseley and David Butler looking at educational psychology. So if we bring in these concepts of neurophysiology into our discussions with patients, it appears that that can assist them understand their pain better and their experiences when they move, when they feel things, when they change their sleep pattern, etc. It also has shown some evidence of effectiveness in reducing short-term pain levels, disability, and engagement in treatment. So some of this concept should come in pre-injury. Basic analgesic plan includes the antihyperalgic role of paracetamol, but also then the anti-inflammatories. Our preference these days is for meloxicam. Celecoxib is pro-coagulant, and so in the post-operative phase, it may increase the risk of DVT, whereas meloxicam sits between a COX-2 selective and a non-selective anti-inflammatory. Ibuprofen and naproxen may increase post-operative bleeding and has higher rates of stomach and renal issues. Adjuvants that you might consider include turmeric or curcumin, Low-dose naltrexone, showing some evidence of decreasing neuroinflammation, particularly for those where there's a strong nociplastic component to their pain. Opioids, morphine, oxycodone, fentanyl, hydromorphone and methadone. There's a number of changes to the market at the moment. So hydromorphone, slow release, has been removed. Fentanyl is now much harder to utilise, so we're really left with oxycodone, and there are some pharmacological preferences why we would use this over morphine, specifically with regards to their metabolites. And then there's a range of adjuvants. You'll see clonidine used much more aggressively, and when my dog had surgery recently, I wasn't surprised, but the anaesthetist used clonidine and was sent home with clonidine. Good anxiolytic, an analgesic in itself, and it lowers that neurological response, muscle tightening response to pain, and complements opioids well. A lot of patients don't like it due to its sedative effects. Nortriptyline or amitriptyline reduces that sensitization component, so anyone with major trauma will end up with a tricyclic for a 6 to 12 week period to try to reduce that sensitization and promote recovery. Then you've got the gabapentinoids, which is specifically for neuropathic pain or the neurogenic upregulation that may occur in inflammation. And then atypical antiepileptics you may see used occasionally. Ketamine, I must say, I'm seeing more of this in private where there's oral ketamine being utilised. Psychiatrists are now starting to use it for depression through the Epworth and other private centres. So we may need to become more conscious of the use of ketamine in the community. The atypical opioids remain the mainstay, and the reasons for it is benefits in both efficacy and less gastrointestinal side effects, and to a degree, less respiratory depression. For buprenorphine, coming as Temgesic, sublingual or Norspan at the lower doses for analgesia, you only get in maximal doses 50% reduction in your minute ventilation. So it's hard to fully overdose on Temgesic or buprenorphine alone. Whereas with tapentadol, if you do push the dose higher, you will get a dose response curve in regards to respiratory depression. However, the efficacy drops away and you do get the peak effect with the noradrenaline in that higher doses. So in general, at analgesic levels, tapentadol is safer than the full-strength opioid. Now, you'll be aware of, in the community, a lot of concerns from government, and the previous government in particular, who initiated a number of PBS reforms, but also introduced and set up the clinical care standards for opioid analgesic stewardship and acute pain. This specifically is targeting dispensing from hospitals. So you will find patients are now being dispensed with less than 7 days of opioids and often less than 3 days of opioids, and smaller amounts of immediate release opioids, even though they may have acute nociceptive pain. I saw one the other day who had a complicated arm fracture, was waiting for surgery, wanted to let the swelling go down, and really just got 10 endone to go home with. And they had poorly controlled pain for that period between acute ED admission and plan for surgery. Now, there's some other pushes, emphasis in this document about improving documentation and communication, including to GP practices. However, I don't think anyone's really thought about how hard it is to ring up and get a GP appointment within 3 days of having an ED presentation. What is viable? So what we're looking at Royal Melbourne is improving our pre-operative process, educating patients, identifying those at risk, modifying their opioids if we can, and then having a clear plan, having some discussions and documenting that plan with an appointment follow-up. And that appointment might be with their primary team, it may be with their general practitioner, but if need be, we'll provide transitional pain services. So these are people we're identifying who may be at risk of developing persistent pain, may be at risk of developing opioid dependency, and we should be seeing them earlier rather than later. There's also pressure by the government to say opioids don't work in chronic pain. However, there are some studies showing some benefit, specifically benefit in those with nociceptive pain of significance. So the larger population studies do identify that there's a lack of evidence of benefit in the population, and there's a significant risk of harm on a population basis. However, as I've mentioned, aggressive use of opioids appeared In an orthopedic group, randomized controlled study, older population with joint replacement surgery, the more opioids they got, the less they needed opioids at 6 months, the less chronic pain, and they had a greater range of motion of their knee joint replacements. So there is a role for aggressive early management and then transitioning into a different strategy that will improve recovery. And then there's one study looking at randomized controlled trial over 12 months with morphine, not the best strategy alone, versus non-steroidal paracetamol, gabapentinoid plus access to tramadol, and they had equal efficacy. In both had sustained reduction in pain and improved function. The group that they were talking about, however, had defined pathology. So they had defined significant spinal degenerative change. They had defined knee joint arthritis or hip joint arthritis. Then we're looking at pain programs. So specifically, these are interdisciplinary programs trying to target the cognitive component and the physical consequence of pain. So it would be important to identify barriers, so specifically readiness to change. Do they understand this concept of pain education? Are there any hurdles or barriers? Specifically, is there a legal case coming up? Is there a solicitor's spouse or family that is preventing patients from improving? And the goals will really depend on the degree of severity. So if they're significantly disabled, they will need a 100 hours or 120-hour program to really reap the rewards and demonstrate the benefits. But if they're midway and they're not doing too badly, they can get by with a shorter, sharper pain program. And this allied health strategy is targeting those consequences, so those neurological consequences of nociception that Nicole's also mentioned and sort of talked about, which is trying to reconceptualize and remove the threat value of pain and the threat of movement. So this would be graded exposure, included leading into graded activity, tackling the boom-busting cycle that a lot of patients report, cognitively restructuring and challenging catastrophic beliefs, and targeting those solicitor systems that may reinforce disability. When we talked about earlier about Pilates, and if you look at other studies, there are some studies of Tai Chi, yoga, but also meditation. I think it's all about one, movement, but it's two, about planning to do the movement. So it doesn't really matter which technique you're doing, it's the neurological activation of movement networks and then the consequence of that movement networks that leads to a degree of pain control and increasing your descending inhibition. For a long time, I used to refer to this study of looking at ex-elite athletes, and I used to say, look at this, orienteers have lower rates of back pain than the rest of the population versus rowers and skiers. But then I also think a professional rower and a professional skier is a different type of person to a professional orienteer. I could imagine they have quite distinct psychosocial features, and they might be much more relaxed walking through the wilderness versus competing at high end with high compression loads and overusing a simple movement that can lead to that repetitive thing. Key part to these ex-elite athletes is cross-training, which Nicole's talked about. It's not just one repetitive event, it's actually mixing the training up to get the best outcome. Now, I'll quickly move through a few comments about those that are on opioids. And this is the data that drove previous government to push a lot of these opioid reforms. So they said there's an association here based on these two maps showing areas of higher prescription have higher rates of unintentional drug-induced death. Therefore, they jumped to the conclusion, if we reduce the amount of opioids being prescribed, we should get less deaths. Problem is, they haven't really interpreted the data properly. So when they look at overdose-related deaths, there appears to be three cohorts. There's the actively addicted, misusing group that overdose with heroin or a pill combination. There's a group who do have mixed prescription toxicity that may be inadvertent and often there and have coexisting medical conditions. And then there's a group that may be up to 30% where it is self-harm or suicide. and that is commonly with mixed drug toxicity. There is higher rates with methadone, and there's obviously clear links with benzodiazepine. And I think World Awareness Day, Overdose Awareness Day is tomorrow, and there'll be a focus on the psychoactives, so specifically benzodiazepines. So benzodiazepines are actually higher in overdose deaths than prescription opioids, but it's the combination. And it's the combination of respiratory depression with an opioid and another sedative agent. And what happens is the opioids leads to raise in the CO2, and that dilutes oxygen. You combine that with sleep or a psychoactive, and you have prolonged periods of hypoxia, particularly in the morning. So 5 a.m. to 8 a.m., prolonged periods of hypoxia puts people at risk of having arrhythmias. So often patients with prescription opioid overdose have precursor events where they're drowsy, they're hard to raise in the morning, they're confused, and then they pick up, and then they have another event the next night. They might think, I had a poor sleep last night, I'll take an extra Valium tonight, and that tips them over. So that appears to be the strong mechanism. We get by in hospital by giving supplemental oxygen. As an outpatient, we're now looking at risks, and we're saying that risk is increased once you're up to 80 to 100 OMED per day, and that this cohort, particularly if they have a benzodiazepine on board, they need to be provided with take-home naloxone. And these things were also the driving force for SafeScript. And I just want to make one comment. You'd be very familiar with this, but it's been a bit of a bugbear of mine that the coroner's courts asked for this, and they've identified the need, and in this is this view access history. So there's now a record that if someone prescribes without looking at the history and there's a bad outcome, then there's a record there that we should be educating those people or supporting or even potentially removing them from their practice. So this is what's changing practice, is good GPs know to access SafeScript before prescribing, but the coroner's court can identify this if they get the SafeScript data. However, they have to apply for the SafeScript data. They don't get it automatically. And this has been a bit of a breakdown because in the coroner's court, they'll do a CT scan and they'll do a toxicology screen. So by the next day, they will know the structure of the body of the deceased person, and they'll know their blood screen, including their medications, but it will take them weeks and possibly months to get the data off SafeScript. So to close that loop and identify doctors, prescribers at risk, potentially patients at risk, identifying that through the Department of Health could occur and make the benefit of SafeScript greater. Then I want to talk about opioid revision. In America, they've gone hard in reducing prescribing, yet they've now got 3 studies on a population basis that have demonstrated an increased rate of deaths. So they've moved from this cohort of inadvertent deaths that has appeared to come down, but the rates of suicide have gone up and the rates of addiction death has gone up. So fentanyl deaths gone up and suicide because of distress. And that is combined with less opioid tolerance because the opioid's been withdrawn. So they've gone back to a standard dose or sourced it elsewhere, and they've fallen into overdose. There is risks with weaning the opioids. 1, it's hard to do, but 2, it leads to this chronic psychological state or psychoneurological state of anhedonia, depression, anxiety, and agitation. And this is the hardest part to manage with an opioid taper rather than acute withdrawal with diarrhea. There's also a number of service provision issues and difficulties in accessing care. So we should be doing active management approaches, specifically in rural areas and that outer urban area where there's higher rates of death, and providing support strategies. I think if a person is on an opioid long-term, they need a sleep study. We know sleep disordered breathing is common in those on oral opioids long-term. They need dental review, assessment of their hypothalamic axis, because often men are hypogonadal, women may be amenorrheic, and they may have a blunted cortisol response in the setting of infection. And then there should be some containment approaches by having legal settings in place, having good documentation, having the family engaged with regards to stabilisation and then gradual dose weaning or dose reduction. There is now a Victorian Opioid Management ECHO managed through St Vincent's Hospital, which has been set up with once a month. This will focus on prescription opioids. So you are welcome to access this and look to see if you can get some support and some guidance on managing the complex patients with aspects of dependency and opioid use. Everyone tells me, and I've done a study looking at the wait times, that it is too long. It probably is too long, but most of the hospitals do have a process so that if you're at risk or patients at risk, they will be screened and they will be brought forward into a subacute or urgent stream, or they can be accessed by telephone. So most of your complex chronic pain services will have a pathway for more rapid access and support. Now, I'll just try to keep this brief on cannabinoids. So cannabinoids have a regulatory role within the system. There's a suggestion and a theory that in some patients with functional pain, fibromyalgia, irritable bowel syndrome, migraine, that there may be deficient in the homeostatic processes that are influenced by endocannabinoids. And that this product of medicinal cannabis includes multiple numbers of agents. We know about THC and CBD, but we don't know enough about cannabinol or cannabigerol, but there's interest in this from a scientific perspective, isolating it and to see what activity occurs. We know it's lipophilic, so it's rapid onset. THC goes rapidly into the brain, and that's reinforcing and potential dependence forming. It has a longer activity when it's given orally, and it has variable bioavailability. Interestingly, it's actually improved if you eat it with a fatty food because it's lipid soluble. THC is psychoactive. It's actually a partial agonist. So when you look at synthetic full agonists of CB1 or CB2 receptors, they have high rates of psychosis. Okay, so it's not a given that THC, because it's a partial agent, that it will cause a psychosis, although some patients are at risk. If you're using THC only and in high doses, yes, you become at risk of getting psychomimetic long-term effects, including psychosis. It has some analgesia in animal studies and likely human studies in neuropathic pain and the sensitization component, but not in acute nociceptive pain. Whereas cannabidiol isn't psychoactive, has a mild anti-inflammatory role, anxiolytic, and in high doses anti-epileptic. It modifies the THC toxicity. So I don't prescribe THC alone. You'll see this in the recreational activities in North America, and you'll see it in some of the commercial groups who are giving high dose THC without much cannabidiol, because cannabidiol will protect you from the psychomimetic and the psychosis risk of THC. Royal Melbourne has a policy. We are keeping people on it if they come to hospital. We're not encouraging vaping because the peak levels are too high, and we're predominantly, if we're using it, we're predominantly using CBD. And what have they shown overseas? They've shown that the older person can tolerate it quite well, and many prefer it to opioids. It's helpful for behavioural disturbance in a subgroup of people with cognitive impairment, and it's helpful for sleep and health-related anxiety. So I think this is where the future will be. It will be a CBD predominant product in the older person who will help reduce their reliance on opioids. It also assists with that aging component. They prefer the CBD. So when they have access to THC and CBD, they prefer the CBD products. So there's a number of human studies going from quite good animal evidence. The human studies are poor. So the meta-analysis shows a number needed to treat of 24, but a number needed to harm of 6. So within a population, not many people respond, but in that population, there can be responders. Most of the medical groups, including the Faculty of Pain Medicine, do not support its use. But I would argue that it's being used for quality of life, and it's being used, if you look at human experimental pain, it leads to deconnection of the affective and the frontal lobe from the sensory lobe. So they still feel the pain, but they're not distressed by it. And so for some patients, it works well to take that distress component out. It lowers their opioids and allows them to sleep And over time, they can get benefit in their pain report, but it's not a dose-response relationship. Opioid reduction has been demonstrated in animals, it's been very difficult to convert that into humans. It's probably a subpoint of humans where the benefit in opioid sparing by adding in THC can be demonstrated, and it's more likely to be codeine and neuroinflammatory opioids rather than full-strength opioids like heroin or oxycodone. And then there's safety concerns. So ironically, I know the Victorian government are about to do a study, but there's a study out of Norway, I think, or Netherlands, which is very well designed, demonstrated some improvement in driving after 6 hours. So of the 6 hours on the agent, their driving is impaired, yes, but after it, it's actually improved compared to control, probably because they're more relaxed and so they have less anxiety. So there's an interest here that it may be that just in the therapeutic dosing phase, people shouldn't be driving. There's also a clear link with alcohol. So in America, they're looking at this level, cannabis is acceptable, 5 micrograms per litre. However, if it's got any alcohol on board, that drops down to 2. So there's a synergistic impairment when used with alcohol. I think we will get to the point of having this concept of drug levels of cannabis, and someone will challenge it in the courts. At the moment, any cannabis is illegal. I have concerns about in practice, and that is basically that there's lack of due maybe diligence and consideration of drug interactions and the holistic view of pain. Rather, it's about prescribing and delivering the product and linking that product and having a bit of a slice of the action when you're selling the product. And they're not necessarily saying, well, what's the best strategy for this patient and their healthcare team? If we do it at Royal Melbourne, we do it after multiple assessments, lots of consent process, and we're careful with other drugs, specifically anticoagulants. If they're coming to theatre, we try to stabilise them pre-op, recognising that those that smoke cannabis appear to have a higher experience of pain post-operatively. That's where I'm going to cease, but this is a quick look at what we do at Royal Melbourne. Yes, we do have a strong acute pain setting. We're trying to develop a more rapid access, sort of acute, subacute phase, and then we have persistent pain services based at Royal Park and linking into Merry Health and Western District Health Service. I know I've just gone to time, or a bit over time, but I'd be happy to take any questions or look at what's mentioned in the chat.
There's one question in the chat for you, Malcolm.
Yep. Yep.
Can you read it?
What's the impact
What's
of
the impact?
for
Yep.
osteoarthritis? Okay, so CBD alone has a mild anti-inflammatory effect, and it may have a peripheral role in those with a inflammatory component to their arthritis. I mean, you'll see people with arthritis that have strong inflammatory reactions around their joints, or you may have people with arthritis who have strong neurological upregulation, so they have a sensitization component to their arthritis. So CBD may have a peripheral role. To me, it's more about treating the central aspect of inflammation, and with prolonged pain, you get glial cell activation and neuronal upregulation. CBD may have a role for reducing that component. In conjunction with a tricyclic, I feel it's okay because, again, slightly working on slightly different mechanisms. Tricyclics working through neuronal pathways rather than as an anti-neuroinflammatory. So I would be acceptable to combine that. Airways disorder I'm not as familiar with. I don't see CBD as a contraindication in someone with airways disease. CBD itself is not sedative. Tricyclic, yes. Do you increase the risk of respiratory problems? Only really if they have upper airway issues, so sleep apnea or sleep disordered ventilation problems. That is different to THC. If you're seeing patients with THC, and we do see patients with a combination THC CBD to assist with their sleep, but we're cautious if they're also on an opioids, because I see that as a sedative and you will increase the opioid risk. And so we would want to see dose reduction of their opioids in order to, to maintain a THC component of the cannabis at night. But we do the same risk if we're adding in a tricyclic to an opioid, if we're adding in a gabapentinoid to an opioid. And when you look at the statistics coming out of the Department of the forensic labs, all those numbers are basically, has this person in that system, is this drug in that system? And it's about 70 or 80 with a gabapentinoid deaths in Victoria. And it's about 40 with a tricyclic, or 40 or 50. So they are contributing. Any sedative agent will contribute with an opioid to pharmacologically related inadvertent death.
Just for the recording, I might just read out what that question was, Dr. Hogg, and that was, sorry, now I've lost it. What was the impact of CBD for osteoarthritis in conjunction with TCA and airways disorder collapsing, likely increased risk of CNS depression?
Yeah. So there is the QR code, and we do value your feedback, and would be keen to sort of understand your educational needs and support. I think the health pathways are good, and it does give a lot of guidance. But I'm thinking, how do you do it rapidly? And in many ways, chronic pain isn't managed rapidly. It's managed with a holistic, multi-dimensional assessment that takes time. So often it's several visits. So that allows you to sort of engage the health pathway to potentially identify those factors you want to know about, and then on refer as required to the appropriate service.
And Dr. Hogg, we've had a couple of other questions. One is CBD for fibromyalgia and schizophrenia patient. Is it safe?
Yes. So whenever I'm using it in patients who have significant psychiatric disorder, I get the clearance from the psychiatrist. The trial at Origin is up to 300 milligrams of CBD in anxiety, and it's now in its open label phase, and they feel that it is safe in those with psychosis at risk. And if anything, it's antipsychotic. You do need the good purified CBD. So you need 100 milligrams per mil, 99% type purity with less than 1% THC or other cannabinoids, so that you can give 100 milligrams or 200 milligrams a day of CBD and you're only giving a very small amount of THC. If you've got one that's less pure and you go to those higher doses, you are then still giving them moderate dose THC, and they can still have the psychomimetic effects. So one, it's about assessing them. Two, if it's CBD only, it does appear to be safe, but I'd clear it with the psychiatric team. And three, which product are you using and what dose?
Thank you. And just the other question that's in the chat is, what is your approach with inherited people who are chronically high dose, Lyrica opioids?
Yeah, okay. Quickly, I didn't quite cover fibromyalgia. So I see fibromyalgia as a central sensitization, functional, neurological pain condition. And my preference would be something like low-dose naltrexone as an anti-neuroinflammatory, but potentially, yes, CBD may have a role. What's the approach with inheriting people? Again, I look at that risk profile and where and how did they get there? Why are they on high-dose opioids? Whenever I see someone on opioids more than 100 OMED, I'm thinking, is there a psychiatric comorbidity here? And I want to know about it, and how is that best managed? Because if I can get their anxiety managed, then I can get their opioid doses down. I lay out the issues about why they're taking it and what the benefit, and get them to identify, so motivational interviewing, identifying aspects of what the benefit is of their opioids and what the potential goals or gains would be in opioid dose reduction. And some of that includes less opioid-induced hyperalgesia and potentially better pain control. It's paradoxical, I know, but we have to convince that to the patients that it would be better to get your doses down and I aim for buprenorphine if they're on a full-strength opioid. I don't think after years of being on a full-strength opioid that they're going to be able to easily get off them to zero. Even when we see people who go heroin, methadone off, they remain hyperalgesic for years afterwards. So they always remain at risk of developing persistent pain. So I tend to try to engage them, identify the risks and why they're at that point, and then slowly work on dose reduction. As you come down, you need to be willing to manage distress and anxiety, and that might mean family, it might need a psychiatric assessment, it might mean using SSRIs, for example, for high-level anxiety. And complex trauma fits in that. There's no doubt that people who have a complex developmental history, trauma history, anxious, their opioids treat their anxiety as much as their pain. And so you need to manage that. Now, I'm not sure about re-exposing them necessarily, but at least demonstrating the link, identifying the link and having a plan to manage their complex trauma and from a sort of behavioural perspective. Lyme disease, I'm not aware of it causing chronic pain. However, any, I suppose, chronic inflammatory issue, and we were very concerned about COVID causing this, and there was a bit of a bump in pain in that acute recovery phase of COVID, but COVID hasn't led to a huge influx of patients with chronic musculoskeletal pain or chronic neurological pain post-COVID. So it is possible that acute inflammatory infectious diseases can cause heightened neurological experience in that phase, but there isn't a lot of evidence that they persist long-term de novo. If you've got COVID and you're lying in ICU, you can get precious areas and nerve injury. Yes, you can get Guillain-Barré. Yes, that's a separate entity to just run-of-the-mill inflammatory infectious diseases.
Thank you. I'm conscious that it's 8:10, and I don't think we've had any other questions come through. So before we close, I'd like to encourage everyone again to scan the QR code that's on the screen. We really do value your feedback, and I'd really like to thank Dr. Hogg and Nicole so much for presenting this evening. And as the messages have come through from our education team, you'll receive a copy of the slides and of the presentation sent to your email. So unless any other final questions, I think we'll close for the evening.
Thank you.
Great. Thank you so much, everybody.